Interesting talks for the day with colleague Dr. Mike Morley. Mike, over to you.
Thank you very much. I'm going to talk a little bit about pacemakers, and I thought that it'd be quite useful to talk about a patient journey from admission through to follow-up. So for the purpose of this talk, I'm going to promote you all to cardiology registrars, and you're going to go and see a patient in A&E late at night. It's a 79-year-old patient who's been brought in by the paramedics with a loss of consciousness. He's accompanied by his daughter, who's witnessed the collapse, and he told he's now stable. He's sat up drinking a cup of tea. He's hemodynamically stable with normal saturations, respiratory rate, and blood sugar. So as you're walking to A&E, you should be thinking a little bit about what the possible causes of syncope are. So just in the chat, if you would, just throw some causes of syncope at me, not necessarily cardiovascular ones. Okay. So, yeah. So there's lots and lots and lots of causes of reduction in conscious level or loss of consciousness. The primary sort of brain problems such as seizures or cerebrovascular accidents, and then the others relate to the brain shutting down for a particular reason. That might be due to hypoxia or hypoglycemia, or to drugs or alcohol, or to a drop in blood pressure, which is the more cardiovascular causes, the classical vasovagal, and the situational syncopes that you've alluded to, things like micturition syncope and cough syncope, and so forth. And all of these syncopes have just a slightly different characteristics, and that's loss of consciousness. So patients with vasovagal syncope will complain of a prodrome, of feeling hot and sweaty and sickly. Patients with cardiogenic syncope, maybe no warning, sudden loss of consciousness, injury, and a rapid recovery. And patients with seizures may be seen to fit, maybe tongue biting, incontinence, and a post-ictal period. So the story is pretty crucial to working out what's going on with the patient. So when you get to A&E, you find the history is that he was sat down at the table. He suddenly slumped over and banged his head. And this episode was witnessed by his daughter. So she said he looked pale. He wasn't shaking, came down very quickly and was soon back to his normal self. In terms of past history, he's normally fit and well, not on any regular medications. There was nothing to find on examination, and there was no drop in his blood pressure. So the next thing you do is to review his ECG. So would anybody like to comment on what they can see on the ECG? Okay, so we've got a right bundle branch block. What else does anybody see? Go. Yeah. Good. Okay. Yeah, looks long. Right. So if we look at the rhythm strip on the bottom in lead 2, first thing we can say is the patient's in sinus rhythm. So we've got P waves, and every P wave is followed by a QRS complex. The PR interval is defined as the timing from the beginning of the P wave to the beginning of the QRS, and that should so we've got a QRS duration here, which is about 6 or 7 little squares. So that's prolonged. So that's first degree AV block. If you going on from Joseph's talk, you should be able to recognise the right bundle branch block pattern, the broad QRS with the rabbit ears, and MW. And if we look at the axis, we see that it's negative in 2 and 3. It's isoelectric in 1. It's actually most positive, pointing towards the left shoulder. So this is left axis deviation. And in the context of conduction disease, left axis deviation is suggestive of left anterior hemiblock. That's the 2 fascicles of the left bundle, one of which is left anterior and the other is the left posterior. And so here we've got trifascicular block. So we've got a patient who's presented with a fairly typical history of cardiogenic syncope, with evidence of significant conduction disease on his 12-lead ECG. So we're thinking that this patient is probably going to need a pacemaker, which is fortunate given the title of the talk. So initial management then, so we'll get some IV access, we'll do some routine bloods, we'll admit him to a monitored bed, which in our trust would be the bed on the cardiology ward, on telemetry, seen patients in AAU with bedside monitors, which are pretty useless unless somebody's sat there watching the monitor the whole time. We'll do regular observations and we'll key the patient up for a cardiology review in the morning. So just when you're sat down having a cup of tea, you call back to the ward because the patient has become drowsy, his heart rate's dropped to 30, his blood pressure is only 70/40. And you're faced with this ECG. So would anybody like to comment on this? Okay, so there's lots coming in for complete heart block, and I would ask you all to look again. So let's talk you through it. So if we look at the rhythm strip at the bottom, we can see that we've got P waves. So we've got atrial activity and we've got QRS complexes, so we've got ventricular activity. And you're quite right in saying that you've got more P waves than you've got QRS complexes. So there are some P waves that don't have any QRS complexes after them. Okay. But if we look at the QRS complexes, we'll see that each one is actually preceded by a P wave. And the PR interval for each of these is actually fixed. So there seems to be a relationship between these P waves and the QRS complexes. So this is actually Mobit's 2 second-degree block. Okay, so the next question is, given that this patient is bradycardic and hypotensive and symptomatic, what's your next treatment choice? Okay, so the most readily available treatment is some kind of drug, and you suggested atropine. So let's talk a little bit about atropine. So atropine is a competitive acetylcholine receptor antagonist. It acts by blocking the parasympathetic supply to the heart, which leads to non-competitive stimulation by the sympathetic supply to the heart, with an increase in sinus rate, sinus node and AV node conduction, and can also increase the rate of the ventricular escape rhythms in complete heart block. Has a relatively short half-life, although in certain areas such as theatres and ITU, they may use a longer-acting derivative like a pyrrolate. There are, however, some drawbacks, particularly in the elderly population, which is often the patients that we're treating. So it can cause confusion and agitation and restlessness. So you can convert a patient who is with it and compliant to one who's climbing out over the cot sides and trying to fall over. It does also cause problems with urine retention, some GI upset, and due to the pupillary dilatation, some visual disturbances. Can anybody think of another drug that we commonly use to speed the heart up? Okay, so we've got adrenaline, isoprenaline. So that's right, we tend to use isoprenaline on the cardiology ward. Positive chronotropic effect. It's a beta agonist, and again increases the sinus rate, AV conduction, and can promote and increase the rate of an escape rhythm in complete heart block. Its advantage is that it has a very short half-life, which allows us to fairly rapidly, over sort of 15-20 minutes, titrate it to the right dose in order to obtain a reasonable heart rate and the hemodynamic response that we would require. And it's easy to give through a large peripheral cannula. It does have some side effects, particularly if you overshoot. Patients can feel nauseated and tachycardic and flushed, and you're giving them essentially giving them a sort of an adrenaline type drug. They can become tremulous and anxious in excess, and in patients with structural heart disease, it can sometimes precipitate ventricular arrhythmias. But it's our treatment of choice now, and has allowed us to avoid, in many cases, having to resort to invasive treatments for bradyarrhythmias out of hours. Patients can be maintained on isoprenaline infusion until the next day, and then can have definitive treatment. Okay. So away you go again, and you're called back to the ward because the patient keeps losing consciousness. And this is the ECG that you're now faced with. So would anybody like to comment on this? Okay. Let's see, Joseph's got it right. So if you look at the left-hand side, you can see that we've got a normal sinus rhythm. We've got P waves, we've got QRS complexes, one follows the other. And then on the right of the screen, all that you can see are P waves. There are no QRS complexes, there's no ventricular activity. The atria is doing its normal thing, and the ventricles are standing still. So this is ventricular standstill. And this is a good reason why the patient is losing consciousness. It's an unstable situation. Our drugs are clearly not doing the trick. It's now 2 o'clock in the morning. What are you going to do now? Okay, so there's a couple of suggestions, both of which are valid. One is external pacing and the other is transvenous pacing. Our ultimate aim is to get the patient down to the lab for transvenous pacing, but that doesn't happen instantaneously. Depending on the centre, people may be coming from home. Certainly that's the case in our hospital. And so we need to have some way of temporising and also so safely transferring the patient down to the cath lab for transvenous pacing. So not unreasonable to put an external pacer on the patient. So not all defibrillators have the capacity for external pacing. The defibrillators in certain areas, such as A&E, coronary care, theatres, intensive care, will have the ability to do it. And rather than turning the knob to the left to get shocks, you turn the knob to the right to get external pacing. You place the pads either in the standard position or front to back. And importantly, certainly with our external pacers, you have to put the ECG cables, leads, onto the patient as well, because the external pacer uses the ECG monitoring to determine when to apply the external pacing. So if you don't put the leads on, you can press the buttons as many times as you like, it ain't going to start working for you. Then what you've got to do is you turn the output up to maximum energy. You increase the rate to the rate that you want the external pacing to kick in at and to pace at. You press the mode, which should be for demand pacing, so that if the heart's doing its normal thing, the external pacing won't, and it will only intervene when the heart's trying to go too slowly. And you press the start button. And what you see then is when there is external pacing, you see the patient jolting up and down, and hopefully you have a conscious patient. How do you know if your external pacing is effective? Okay. So the key thing is that you cannot rely on what you see on the ECG screen. You are going to get very large deflections due to the impulses which are being transmitted across the heart. And the idea of external pacing is to deliver sufficient energy to the heart, to capture the heart muscle, to initiate a action potential, which is then propagated and causes a contraction. So you must feel the pulse. Feel the pulse in the major artery, so the femoral artery or the carotids. Seeing electrical deflection and seeing the chest jolting due to skeletal muscle capture is insufficient. Now, the other thing to say about external pacing, if you've ever seen a patient on it, is it ain't very comfortable, and often the patients will need some analgesia or sedation in order to tolerate it for a period of time, which may be 20 minutes, half an hour or longer. Okay, so then we go on to get our patient down to the cath lab, and we position our temporary pacing wire. The temporary pacing wire is positioned via transvenous route. In the case of the picture here, it's been placed via transfemoral vein puncture, passed up the IVC to the right atrium, across the tricuspid valve and down to the right ventricular apex. Other access routes you can consider are internal jugular or subclavian. The advantage of the femoral is that it's quickest in terms of obtaining access and getting the wire in, which in a very unstable patient can be useful. The disadvantage is as soon as the patient gets back to the ward and the nurses sit the patient at 90 degrees, the wire displaces and you lose pacing. The other disadvantage of the femoral route is if it's going to be in for a period of time, particularly if the patients come on a Friday evening and ain't going to get their permanent system until the Monday morning, groins are not a particularly clean sight, and the patients don't really appreciate having to lay flat for the whole weekend. So if the wire is going to be in for a while, then it's probably better to consider internal jugular route, which allow the patient to sit up and is a cleaner route of access. Okay. So you don't get off the hook because you're called back up to CCU. Patients come back to the ward, they were doing all right, but then they're starting to have some brief losses of consciousness again. and you're handed this rhythm strip. So would anybody like to comment on what they can see on here? Okay. So what you'll see on is a rhythm strip. We can see some QRS complexes, and we can see some very sharp deflections in the tracing. And these sharp deflections in the tracing are pacing spikes. Okay. Don't always see pacing spikes. You're more likely to see pacing spikes if the pacemaker system is set up as a unipolar pacing, although temporary pacing wires tend to be bipolar by definition, because the box is not in contact with the patient. And with modern monitoring, digital monitoring, often these pacing spikes are filtered out and smoothed out, so you don't actually see them. So the first two pacing spikes are followed by a broad QRS, and that's what we're expecting to see, because our temporary pacing wire tip is positioned down at the right ventricular apex. The cardiac muscle is stimulated with slow tracking of electrical activity over the left ventricle, leading to a broad complex that on a 12-lead ECG would have a left bundle branch block morphology due to initial activation of the and depolarization of the right ventricle, followed by slow depolarization tracking around the left ventricle, mimicking a left bundle branch block. But then we have some pacing spikes which are not followed by QRS complexes. So these pacing spikes have not been sufficient to depolarize the heart to initiate the action potential at the pacing wire tip and lead to a ventricular beat. So we need to have a look and have an understanding of pacing and the temporary pacemaker box. And if you understand how a temporary pacemaker system works, then really you've got pretty good grounding in how all pacemakers work. So we have our wire going down to the right ventricular apex. We know from our previous tracing that the wire must be somewhere near the heart because we're getting intermittent capture from the pacing. We're going to check that the lead is screwed in tightly to the connections on the temporary pacing box. We're going to check that the battery light is on, and we've got a good battery. It should do. We put a new battery in every time we put a temporary wire in. We make sure that it's turned on to the ×1, and that the pacing box is set to demand. So demand is that it will sense as well as pace, and that's the two fundamental functions of a pacemaker: the ability to send impulses down to stimulate the heart to beat, but also to be able to sense intrinsic activity, and with demand pacing only to pace when necessary. That is, when there's no intrinsic activity or when the heart rate drops below a certain level. So then we're going to have to check a few things to try and get our temporary wire working. So what we can do is we can turn the lower right-hand knob to the desired heart rate. So that's the rate that we want the pacemaker to make sure that the heart can't go slower than. And we can turn the output, that's the size and the magnitude of the impulses that are being sent down the lead to the maximum. So we're going to turn that up to 12 volts. And for now, we're going to ignore the sensitivity knob on the left-hand side. Okay. And then what we need to do is we need to test the threshold. So we need to see how much energy we have to deliver down the lead in order to capture the ventricle and cause the heart to beat. So we'll start at a high output of 12 volts, and we can see that the pacing spike is followed by QRS complex, and we're getting capture. We gradually lower the output by turning our output knob to the left. And eventually we get to a point where our pacing impulse is too small in terms of amplitude to capture the ventricle, and we see pacing spikes which are not followed by a QRS complex. Later on in the tracing, you see an escape beat, which is fortunate. And the threshold is defined as the last energy value that actually reliably captured the ventricle. And so in this case, since we went down from 12 to 4 to 2, the last successful energy was at 4 volts. And so that's our threshold. So then we know that we need to set our output higher than 4 volts to ensure that we're getting capture. And so we tend to, in pacing, we tend to go for twice the threshold as a minimum output. So we might turn the knob up to 8 volts. So then you have a look at the monitor again, and you see this is happening. We're getting some pacing, and then we're getting some pauses with no pacing. Can anybody think about what might be happening here? Okay. So if we look at the strip, you can see we've got a pacing spike followed by QRS. Pacing spike, QRS. We've got 4 of those, so we're happy with that. What we see here then is a pause. And what we don't see is pacing spikes. So this means that the pacing system is not sending down impulses. So there is something stopping the pacemaker from sending down impulses. And this is an example of oversensing. So that brings us on to sensitivity. So the pacemaker can see electrical activity that's passing by the tip of the lead. What it doesn't know is what these impulses are. And so we use changes in sensitivity to make the device more sensitive or less sensitive to ensure that we can get the pacemaker to see and respond to and take notice of what we want it to take notice of, i.e. the ventricular activity, whilst ignoring noise, background noise, electrical interference, far field signals from other chambers, or sensing of the T waves. And so our top left-hand knob on our temporary pacing box allows us to make the pacemaker system more sensitive or less sensitive, depending on which way we turn the knob. If you turn the knob to a higher millivolts, so a higher number, then you're setting the fence higher. You're saying that the pacemaker system should only take notice of any signals which are above 5 millivolts. But in this case, that means that we're not going to see any intrinsic activity. Conversely, if we make the system too sensitive by setting the sensitivity too low, then it means, yes, we can see what we want to see, intrinsic ventricular activity, but the device is going to get confused by seeing other things such as the T wave, and you can get what's called T wave oversensing, which can inhibit pacing. Get the sensitivity just right, and the pacemaker has a simple job now because it's only seeing what we want it to see. And in that way, it can sense intrinsic activity and we get back to our demand pacing. So the simple rule is that if you have oversensing, so you can see here this is from a pacemaker interrogation, you've got ventricular pacing, followed by a ventricular, an intrinsic ventricular beat, followed by some markers on the bottom which suggest that there's some ventricular activity. But when we look at the ECG, actually there isn't. So the device has been set up too sensitive, and it's picking up some noise or some low-level signals, which it's interpreting as a beat, and that's inhibiting pacing. So oversensing leads to underpacing. And the converse of that is that undersensing leads to overpacing. And in this situation, we've got ventricular pacing, spikes marching all the way through, some of which are capturing the ventricle. But we can see that there's some inappropriate pacing spikes because the device is not sensing the underlying intrinsic activity. Okay. So we're going to go on and talk a little bit about bradycardias and treatments. And so you'll be well aware that the classification of bradycardias falls into two groups. There are those related to impulse formation, so sinus node disease, and those which relate to impulse propagation, so disease of the AV node and associated conduction tissue, so the bundle of His. And the reason that bradycardias have such a profound effect on cardiac output and therefore blood pressure and therefore symptoms is because the heart doesn't have much of a capacity to compensate for reduced heart rate. It can increase stroke volume a little bit due to more prolonged filling, but this doesn't compensate for the reduction in heart rate. And as cardiac output is the product of the two, cardiac output can fall quite precipitously with bradyarrhythmias. Whereas with tachycardias, moderate tachycardias, the increased heart rate can compensate for the slight decrease in stroke volume. In terms of symptoms that patients may present with, well, yes, they may present with the typical syncope, pre-syncope, but patients may present with all kinds of other symptoms. They can just complain of fatigue, breathlessness on exertion. They can get chest pain associated with it. In the elderly patients, they may just present with some confusion. Sometimes, paradoxically, patients will complain of palpitations, and it may be a cause of falls in the LD and must be considered as a possible diagnosis. In terms of the causes, well, the most common cause of bradyarrhythmias is age-related conduction disease. That's what we see the most of, sometimes exacerbated by medications. But there's a whole gamut of other conditions which can also lead to dysrhythmias, from primary muscular disorders, infiltrative disorders, infection in endocarditis, complications of procedures such as valve surgery or TAVI, and if you live in Salisbury, nerve agents. So there are cardiac and non-cardiac drugs which can affect the heart rate, as you know. Beta blockers, calcium channel blockers such as diltiazem, digoxin, and a whole gamut of antiarrhythmic medications. And ivabradine, which you will have heard of in the earlier talk on heart failure, which is has a selective effect on the sinoatrial node. But there are a whole list of other medications that elderly patients may be on, which can also affect conduction and both initiation and propagation of impulses. So we move on now to permanent pacing, And a permanent pacemaker is really just a slightly more sophisticated version of our temporary pacing system. It consists of a pulse generator, which is it's a titanium box containing a battery and some electronic circuitry with a plastic header which allows for the connection of the leads. Battery life on a typical pacemaker these days is somewhere between 10 and 15 years. And the reason that pacemakers can last so long is that the current drain for each impulse is tiny, because the resistance of the leads is so high, and because the impulses are of such short duration. So typically the impulse will be 0.4 milliseconds, which means that you're only getting about 30 seconds of current drain a day, or about 3.5 hours of current flow per year. And in the life of the device, you may only have 30 to 40 hours worth of actual current flow. And that's the reason that pacemakers can last for such a long time. The leads are their insulated wires, which deliver electric impulses from the generator down to the heart, and then also carry sensed impulses back to the device. The leads that we implant are of two types. The more traditional leads were called passive leads. They're tined, they've got little anchors at the end which snag into the trabeculae, and then subsequently the tip is fibrosed to the heart muscle. The disadvantage of this is that you can only position the leads at the right ventricular apex or at the right atrial appendage in an atrial lead, whereas the active fixation leads, which use a deployable corkscrew mechanism, can be secured in different parts of the heart. And that can be useful, particularly when you have problems with stable position of the leads, or if you have poor thresholds or poor sensing when positioned at the apex. Put them together and put them in a patient, and you've got the pacemaker circuit consisting of the generator, the leads, and the patient's tissue. And depending on how many leads you put in, you can have different kind of pacing systems. So the simplest pacemaker system, which would sort of mirror our temporary pacing wire system, would be a single chamber ventricular pacemaker. Alternatively, if you have patients with pure sinus node disease, so perhaps very young patients, then you may consider just positioning one lead to the atrium. Although these days we tend to always put a second lead down to the ventricle as a backup. Dual chamber pacemaker, we position two leads, one to the right atrial appendage and one to the right ventricular apex. And this allows us to pace or to sense atrial and ventricular activity and to maintain physiological AV synchrony. So I just want to mention a little bit about pacemaker codes. And these are how the pacemakers are programmed or told to function. But sometimes we use these abbreviations interchangeably to describe the various pacing systems that we implant. So a ventricular single lead pacemaker we may describe as a VVI pacemaker, and a dual chamber pacemaker we may describe as a DDD pacemaker. So the pacing modes describe how the pacemaker is going to behave. So the first letter is the chamber which is paced. The second letter relates to the chambers or chambers which can be sensed by the pacing system. And the third letter describes how the pacemaker responds to a sensed event. And I'll show you some examples of this in a second. The fourth letter, which is sometimes added on, which is R, so people might talk about DDD, R pacemakers, relates to the fact that modern pacemakers have rate modulation. They're able to detect intrinsic activity of the patient and speed up and slow down the heart rate to try and mimic normal physiological changes in heart rate. So, question is, what is the heart rhythm and what kind of pacemaker does this patient need? Why don't we start with the rhythm? Okay. So the rhythm is atrial fibrillation, and the rate is slow. So if this patient's having symptoms related to atrial fibrillation with a slow ventricular response, we may consider giving them a pacemaker. And what kind of pacemaker are you going to give the patient? Are you going to give them a single chamber ventricular pacemaker or a dual chamber pacemaker? Okay. So a dual chamber pacemaker has a lead to the atrium and a lead to the ventricle. This patient is in chronic atrial fibrillation. What is the use of the atrial lead? All it will tell the pacemaker is that the patient's in atrial fibrillation, and the pacemaker will then ignore it. So in actual fact, for somebody who's in chronic atrial fibrillation, there is no point in implanting an atrial lead. And therefore the patient just needs a single chamber ventricular pacemaker. And we would then program this pacemaker VVI, so that which is sensible, because that's where our lead is, and the chamber that is being paced is the ventricle, the chamber that can be sensed is the ventricle. And if the pacemaker detects intrinsic activity, if it senses an event, it will inhibit the pacing of the device. So when you see an ECG with intrinsic activity and no pacing, then that could be appropriate, because if the heart rate has not dropped below a certain rate, whatever you set the pacemaker to, then the pacemaker may well just sit back and let the heart get on with it. And only when it sees the RR interval trying to drop below a certain level will it intervene and send pacing impulses to fill in the gaps. So if we set our pacemaker at VVI 60 or 60 beats per minute, then what the pacemaker does is to pace. It waits a second and then it paces again. It waits a second and it paces again. However, if after it's paced and whilst it's waiting that second, it senses intrinsic activity, that inhibits the next pacing spike, which would have fallen at the cross. It restarts the stopwatch for the pacemaker. It starts its timer again, and then waits another second from the sensing of the intrinsic activity before it puts the next pacing spike in. And this is how demand pacing and how the timing works. Okay, so what rhythm does this patient have, and what pacemaker system are you going to implant? Single or dual? So any shouts for the rhythm? I can see P waves. I can see QRS complexes. And then I'm trying to work out whether I think there's any relationship between the P waves and the QRSs. And in this case, I don't think there is. I think that the atrial activity and the ventricular activity are completely independent, and that this is complete heart block. And in terms of the pacemaker system, well, if we've got sinus rhythm, then we want to maintain atrioventricular synchrony, i.e. atrial contraction followed shortly after by ventricular contraction, then we need to be able to sense and pace in both chambers, and so we should put a dual chamber pacemaker in. And we program that DDD, because both chambers can be paced, both chambers can be sensed, and the response to a sensed event is mixed. A sensed atrial event will trigger a AV delay of 200 milliseconds, during which time the pacemaker will look and see whether that atrial beat is conducted down normally to the ventricle. If it is, then the next ventricular pace beat will be inhibited. And if it isn't, then the ventricular pace beat will be triggered. In that way, we can get an A pace followed by intrinsic conduction and V sense, or we can get an A sense followed after a fixed delay by a ventricular pace. You can also have A sense, V sense, and you can have A pace, V pace. So there are 4 different ways in which the device can function. But the ultimate goal is maintaining AV synchrony and only pacing when required. As we said, the 4th letter R relates to rate response. There are various different ways in which pacemakers can detect activity. Some are a little bit like your Fitbit or the pedometers that you can attach to your belt. It detects movement and translates that into what it thinks the patient is doing, and therefore how fast the heart should be going. When the patient stops their activity, the pacemaker doesn't just suddenly drop the heart rate back to baseline, but it can just slowly drop it down as it would normally do in URI. It can have a slightly slower rate if the patient is inactive, and you can even program it so that the heart rate goes slower still during the period of time when the patient's likely to be asleep, or that function automatically would switch off as soon as motion and activity is detected, for example, if the patient gets up in the night to go to the loo. How's a pacemaker implanted? So this is our basic implant kit. Pacemaker is implanted in the cath lab under fluoroscopy. It's done under a local anaesthetic, usually takes about an hour. Route of access usually on the left-hand side via 2-inch incision with a pocket formed usually on top of the muscle, so pre-pectoral, although occasionally in patients, if they've got very limited skin cover, we can make the pocket under the pectoral muscle, so subpectoral. And vascular access is achieved via the veins, either the cephalic vein or the axillary vein. And then under fluoroscopy, we just follow the plumbing, positioning our wires down to the heart. Cephalic is to be found in the groove between the deltoid and the pectoral muscle, and can be cannulated by direct vision. The advantage of the cephalic route is that there's no risk of pneumothorax because we're not poking around under the collarbone. And from the point of view of the need to extract pacing systems for infection, for example, leads implanted by the cephalic route are easier to extract. So here's our cephalic vein that we have dissected out and secured. We tie it off distally and secure it with a loose suture proximally. We make a little nick in the vein, use a little plastic vein lifter to open up the lumen of the vessel, for which we can then slide wires down using the Seldinger technique. For our axillary vein puncture, so we take advantage of the fact that the axillary vein runs over the top of the first rib under the clavicle as it transitions to the subclavian vein, and we make our puncture under fluoroscopy, positioning our needle over the first rib. And the advantage of this is that we aim for where we think the vein is going to be, and if we hit it, then that's fine. And if we miss it, then the next thing we're going to hit is bone. We're going to hit the rib. And if we hit the rib, we don't hit the lung. And if we don't hit the lung, we don't cause a pneumothorax. So this is the advantage of the axillary vein puncture over the subclavian or blind puncture under the clavicle. The other advantage is that with the more medial subclavian puncture, you can puncture make the puncture through the ligaments which attach the first rib to the clavicle, and over time, just with patients' arm movements, that can lead to bending and fracture or damage to the lead. So axillary vein puncture is preferential to subclavian in terms of reducing the risk of pneumothorax and lead damage over time, but actually a little bit more difficult to extract often because you can cause some periosteal reaction and irritation, which can lead to some calcification around the puncture site, which can make lead extraction more difficult. Once we've got into our vein, whichever one we're using, then we pass a wire down. Over the top of the wire, we can then pass a splittable sheath, and then by removing the wire in the dilator, we're then able to position our lead down to the heart. The leads have a hollow core, which allows us to pass a stiff wire or stylet. Without the stylet in position, the lead is a bit like a piece of string, and trying to push a piece of string in the direction you want it to go is near impossible. With the stylet and with shaping the stylets, we're able to make the lead stiff, and that allows us then to push the lead forwards and position it to where we want it to be. Once we have got the lead in good position, we remove the stylet, and then we can apply some crocodile clips temporarily to the connections on the lead in order to test for sensing and for threshold, as we did with our temporary wire, to make sure that we've got a good signal, and to make sure that we've got an acceptable low threshold, which will maximize the battery longevity. If we are not happy, then we just move our lead and try and position it somewhere else. Once we're happy with our leads and with the measurements, then we can stitch the leads in place to the muscle, connect up the pacemaker with a little screwdriver, ratchet screwdriver to the header of the pacemaker. He gets tucked in the pocket, and then it's dissolvable stitches and a bit of glue to finish. If the patient's done as a day case, they may hang around for 4 hours afterwards. We do some x-rays and pace checks before letting them go home. If the patient's an inpatient, then they may, depending on the route of access, we may do a AP chest x-ray to exclude a pneumothorax if we've had axillary or subclavian punctures, or otherwise maybe just a PA and lateral the next day to document lead position, make sure the leads are not displaced. Patients are generally telephoned now after a week to make sure they're happy that it's healing up okay and there's no signs of infection or swelling or other issues, and we'll come back for their first pacemaker check at about 6 weeks. So this is what a chest x-ray should look like after a dual chamber pacemaker. So the generator with the leads connected at the header, with the redundant lead coiled up in the pocket with the device. You can see the suture sleeves there, which have been sutured to the muscle, and the leads passing down to the SVC, down into the right atrium, with the right atrial lead pointing back up to the right atrial appendage, and the left ventricular lead across the tricuspid valve to the apex, and with no evidence of pneumothorax. So Just to wrap up then, complications which can occur with a pacemaker implantation fall into early or acute and late complications. So with your knowledge of how we put pacemakers in, these complications are fairly logical. So bleeding, not usually any major bleeding. The only major bleeding or bleeding complication that we really worry about is due to perforation and tamponade, which fortunately happens rarely. Usually with perforations, either with temporary wires or with permanent pacemaker leads, the hole seals up of its own accord. Very rarely you might need to temporarily put a pericardial drain in, but usually only drain maybe 50 or 100 mils of blood, leave the drain in overnight and send the patient home the next day. Hematoma at the site of the implant, which can increase the risk of infection. Infection is one thing that we really do worry about, because if a pacemaker system becomes infected, then the only way to get rid of the infection is to extract the whole system. If this happens early on, then that's it's a pain, but it's a fairly straightforward thing to do. But if you had a pacing system in for some time, the leads are stuck in place, then it can be much more difficult, with high risks of complications, including major bleeding. Pneumothorax, which we've touched upon, lead displacements. If the leads are going to displace, it tends to be in the first month or so. Give the patients advice as to limiting the movement of the left shoulder to half mast, so no reaching up to cupboards, carrying heavy bags, or practicing the golf swing or swimming. You can have lead perforation, where the lead passes through the muscle, through the pericardial sac, and heads out into the thorax. And you can have thrombosis of the left axillary vein, which may require a period of anticoagulation. So here's a few examples of complications. So what's the diagnosis? Yeah, so there's pneumothorax. Lung markings only come to here, and then there's this black void, which is the large pneumothorax, presumably due to our subclavian puncture. I've seen pneumothorax on the other side, so the side where the punctures are made, and that can be due to the screw in an active fixation atrial lead screwing through the heart muscle pericardium and causing a pneumothorax in the right lung. It's rare. So A and B is our PA and lateral X-rays taken immediately after implantation, and then C and D are X-rays from patients, from the patient having attended to complaining of recurrent syncope. And what you can see clearly is that the RV lead has moved. It's moved through the heart, out of the heart, and is resting on the diaphragm. And if the pacemaker sends electrical impulses down to stimulate the heart, all it's going to do is cause hiccups. So this patient attends A&E, complaining of symptoms similar to before they had their pacemaker implanted. And just for time, I'll talk you through it. So you can see pacing spikes, which are not capturing. There is no ventricular beat immediately after the pacing spikes. So we've got loss of capture, but also the pacing spikes just seem to be marching through the intrinsic rhythm. So it looks as if the pacemaker is not sensing ventricular activity. So there's a failure to capture, there's failure of pacing, there's failure of sensing. And if you look at the X-ray, the reason's fairly obvious, because the tip of the ventricular lead is nowhere near the heart. It looks like the pacemaker is reeled in the lead, and this is due to Twiddler's syndrome. So some patients, fortunately rare these days, discover that they can twiddle the pacemaker around and flip it over in the pocket under the skin, and as they so it reels in the leads and causes lead displacement. Chronic complications then, infection, erosion, lead issues, either fractures of the wires or insulation failures, and then developing problems with thresholds and sensing over time. Here's a lead fracture. Here's an example of the subclavian crush that I described, with crushing of the lead between the first rib and the clavicle. And so the other thing that we always measure when we check pacemaker systems is the resistance or impedance of the leads. If the impedance is low, then it suggests that there is an insulation break, and if the impedance is high, then that suggests that there may be a fracture. And this is an example of a pacemaker which has eroded and needs to be extracted. This is the pacemaker working, so when they come back to the pacemaker clinic, we'll test to see how much battery is left. We'll test the threshold and the sensitivity and the impedance in the same way that I described with the temporary pacing. And that is the basic pacemaker check that we do every time. There are other things that we can look at at the time of the pacemaker check. We can look and see what rhythm the patient's in or has been in. So if they've had paroxysmal atrial fibrillation, the pacemaker will tell us that and tell us how much. And we can look at other things that we might want to adjust. So is the rate response programmed appropriately, depending on what the patient tells us, what the heart rate histograms look like, we can make some tweaks to that. And we can make some adjustments to the outputs and to the programming of the device to try and extend the battery life and to promote intrinsic conduction and minimize ventricular pacing. And that's really a fairly brief tour of bradycardia pacing.